very much, Ivan. It was very well said. Thank you all for attending to essentially our first of our sonographer series of rounds. So today we're going to be discussing thyroid imaging for the most part, with a focus on TI-RADS criteria, on which our updated thyroid imaging protocol and worksheet is based. So I'll just start with a brief introduction, and then I'll hand things over to Elaine, who's put together an excellent review of the TI-RADS imaging characteristics. So as we're all too aware, thyroid nodules are extremely common finding, with palpable nodules found in as many as 30 to 40% of patients over the age of 50, and otherwise present in 60 to 70% of patients at autopsy or screening thyroid ultrasound, although I actually believe this is probably a bit of an underestimate. A vast majority of these nodules turn out to be benign, of no clinical relevance, with the risk of malignancy for any given nodule quoted in the range of about 4 to 6%. So if you can go to the next slide. So given the very high prevalence of thyroid nodules in the general population, approximately 1 in 20 of which will turn out to be malignant, invariably the management of these lesions becomes a bit of a balancing act between detecting clinically important cancer versus the risk and cost of subjecting patients with benign nodules or otherwise indolent cancers to unnecessary biopsy or treatment. Notably in Canada, 8,600 patients were diagnosed with thyroid cancer in Canada in 2020, only of which 230 went on to die from their diagnosis of thyroid cancer in that same time period. So over the last couple of decades, owing largely to improved imaging, I would suspect, the number of thyroid cancer diagnoses has increased quite substantially in Canada and the US. And given the trend, thyroid cancer is actually expected to surpass colorectal cancer and become the 4th most common diagnosed cancer by the year 2030. However, this increase in diagnosis doesn't really necessarily reflect an increase in the incidence of disease in the population, but as I mentioned, probably reflects largely increased detection owing to better screening imaging technology. Most of these cancers are subsequently treated with surgical resection, and the 5-year survival rate is quite excellent. So if you can go to the next slide. So in an attempt to stratify risk for thyroid nodules, various schemas have been proposed and implemented by various societies and working groups over the years. Most of these have employed, for the most part, a pattern-based system of nodule categorization. So this includes the 2015 ATA guidelines, which up until now we've been using at THP on our worksheets and at least in part in reporting. One of the issues around the ATA guidelines is that it actually left a subset of nodules unclassifiable, with uncertainties of what exactly to do with these nodules, whether or not to biopsy them or not. In 2009, however, there was a TI-RADS system that was first proposed, which was modeled on the BI-RADS system used in breast imaging as a framework. Since then, this has gone through multiple modifications and revisions, with the most recent update coming from the American College of Radiology in 2017, which provides a standardized scoring system and accompanying recommended guidance for both biopsy and follow-up of thyroid nodules. So if you can go to the next slide. So the goals of the 2017 TI-RADS criteria were stated as threefold. First of all, to provide a framework to allow for straightforward and easy stratification of nodule malignancy risk based on a set of defined ultrasound criteria, to standardize and simplify ultrasound thyroid reports in order to better facilitate unambiguous communication between radiologists, technologists, pathologists, and clinicians, and to improve the quality of care and cost effectiveness in management of these thyroid nodules, with an emphasis on avoiding unnecessary biopsy. So in regards to this, the ACR TI-RADS guidelines are overall slightly more lax compared to some of the other classification systems, with a higher threshold for biopsy of certain nodules relative to other schemata. So in studies reviewing the accuracy of these various schemata, the ACR TI-RADS guidelines actually perform quite well with high sensitivity for clinically relevant cancers, approaching 97% in certain studies, and a specificity in the range of 55 to 65%, which is also quite good. And compared to these other classification systems, the ACR system has performed the best of these schemas, at least in most studies, with the area under the receiver operating curve, which is a measure of accuracy for those who are unfamiliar with statistics, being the greatest for the ACR criteria. And as an aside as well, the inter-observer agreement on whether or not these nodules should be biopsied or not is also quite high relative to the other schemata. So if you can go to the next slide. So here's just one of the, this is kind of the summary sheet that's provided by the ACR 2017 guidelines. This is going to actually be posted throughout the ultrasound department at all sites going forward for easy reference for all technologists. And we'll try to get them throughout, available throughout the RAD reporting rooms as well for easy reference there. But just in contradistinction to the ATR criteria, again, which used a pattern recognition based approach to classify the risk of thyroid nodules, the ACR TI-RADS guidelines, again, employs a point-based system. So if you can just click next. Yep, so here at the top, you can see the point-based system where a variable number of points are awarded for 5 separate nodule characteristics, including composition, echogenicity, shape, margin, and the presence or absence of echogenic foci. As you can appreciate, these characteristics are fairly similar to those used to categorize nodules under the ATA guidelines. So we're already familiar with most of these features, but the way that they're applied to risk stratification is slightly different, given that this is a point-based system. So we can go to the next slide. So the points are subsequently totaled, and then these totals determine the risk category of a nodule and the recommended management or follow-up of the nodules, which is then based on the size of the particular nodule. So that's it for me from an introductory standpoint. I'll hand things over to Elaine to take us through the case-based review of these characteristics in greater detail, as well as a review of cervical adenopathy. Then at the end of the presentation, I'll briefly address some of the changes that have been made to the thyroid ultrasound protocol with regards to expectations around lesion documentation and some of the technical considerations. But again, before I let Elaine get started, I just want to thank her again for putting together this fantastic talk. It was a lot of work, but it really shows in how great the talk is. So with that, I'll leave it to Elaine to guide us through the rest.
All right, thanks, Silvio. So to start about TI-RADS goals and performance, we can see here that with each category, as the points increase, you can see there's a higher risk of malignancy. For a TI-RAD 1 or TI-RAD 2 nodule, you see the risk of malignancy is below 2%, whereas a nodule at TI-RAD 5 is around 35%. So the TI-RADS recommendations is to biopsy the most suspicious nodules, usually a TI-RAD 3 to a TI-RAD 5 category based on the size. If there are multiple nodules, you would biopsy the two with the greatest TI-RAD number. And if there's multiple in that category, then it'd be the largest one. Usually when we're measuring nodules too, we want to look at the growth and the interval enlargement of them. And growth is defined as a 20% increase in size of at least 2 dimensions greater than 2 millimeters. or a 50% increase in volume. And I'll talk about that further later. So I'm just going to jump right into the sonographic features of each category of the TI-RADS now. So to start, I have composition. So composition is used to describe the internal components of a nodule. So we have solid or almost completely solid, mixed solid cystic, spongiform, cystic, and sometimes if a nodule you can't tell, then there's a category for that as well. So here's just a graph that depicts the risk of malignancy, and you can see a solid nodule has a greater risk of malignancy, and that's why it's deemed more points. A solid nodule is defined as a nodule that's at least 95% solid. In this image here, we have a solid nodule with an anechoic cystic space. However, if you actually scan through the tissue planes of this nodule, you can see that the cystic portion only takes up a small portion of the nodule's volume. And so that this nodule would actually, if you calculated that cystic portion in compared to the whole nodule, it'd be only 5%, and that would be a solid nodule. Here's another example of a solid nodule, and this is just deemed 2 points. We then have a mixed solid cystic nodule, which is given 1 point. These nodules are at least 50% to 95% solid. Usually there could be some cystic degeneration and necrosis in these nodules, which is why you see a cystic component in it. And sometimes if you can't tell if a nodule is more solid or cystic, it could be helpful to use a cine clip just to demonstrate the volume of the nodule. And next, we have another example of some mixed solid cystic nodules. These ones, you can see the solid area is more of a central component. We call these mural nodules, and it's important in these types of nodules to focus on the solid components. You want to look out for suspicious features such as decreased echogenicity, irregularities and lobulations to the nodule, as you see in this image here, and even some punctate echogenic foci, as you see in that first image on the left there. Next, we have spongiform nodules, which are given 0 points. These are nodules with more than 50% cystic components. This is an example of a large cystic component spongiform nodule. And here we have examples of smaller cystic spaces of a spongiform. Because they're given 0 points, you don't actually need to do any more characterizations for a spongiform nodule, and it would just be benign. This is similar with cystic nodules as well. This here we can see it's just a plain cyst. And so something like this, usually when we're measuring cysts, we'll only measure the largest cyst in the gland and maybe ones that are palpable findings when they're as big as this one here. Other times you might have a nodule where there's a peripheral rim calcification that shadows the entire component of the nodule. This would make it difficult to tell what the composition is. So we would check mark, select that we can't tell what the nodule is and give it 2 points. It's important to be using the correct frequency for penetration of nodules like this without compromising your resolution. Next, we have echogenicity, and this is another very important determinant of risk stratification. Echogenicity of a nodule is determined by comparing it to the ipsilateral thyroid parenchyma and to the strap muscle belly and the sternocleidomastoid. In some cases where there is no ipsilateral parenchyma left, you could also compare it to the contralateral side. So here we have hyperechoic and isoechoic, hypoechoic, very hypoechoic, and again, a nodule where you can't tell the echogenicity. In cases where patients have a known thyroid disease like Hashimoto's or Graves' disease, this comparison still applies where you would compare the nodule to that parenchyma. So here's another graph to depict the risk of malignancy for each echogenicity. And you can see here that the hypoechoic and very hypoechoic nodules are deemed more points because they have higher risk of malignancy. So hyperechoic and isoechoic nodules will be given 1 point, and they're just isoechoic to hyperechoic relative to the thyroid gland. In this example here, you can see part of the tissue is actually isoechoic to the thyroid gland, and part of it is echogenic. You don't really need to worry too much about trying to decide if this is hyperechoic or isoechoic. They're both each given only 1 point, so it doesn't really matter which one you choose. Here are some other examples of an isoechoic nodule here and some hyperechoic nodules. It's important to be able to adjust your gains in cases where it's difficult to tell what the echogenicity is. By decreasing your gains or even decreasing your dynamic range, you can increase your contrast resolution. And then next we have hypoechoic nodules, which are given 2 points. They will be less echogenic than the thyroid parenchyma, but equal or more echogenic than the strap muscle belly and the sternocleidomastoid. So here are some examples of that. And then we have very hypoechoic nodules, which are given 3 points. And these nodules will be hypoechoic relative to the thyroid gland and to the strap muscle and sternocleidomastoid muscles. And once again, you can see sometimes if there's a peripheral calcification and that's shadows, you might not be able to tell the echogenicity. So those nodules will be given 1 point. Next, we have the shape. So the shape of the nodule is determined in the transverse plane. It could either be wider than tall or taller than wide. Wider than tall nodules include spherical nodules, and they'll just be 0 points. And then we have taller than wide nodules, which is given 3 points. And this is when the AP diameter is greater than the width. This is abnormal as the tissues are actually growing against normal tissue planes. Next, we have the margin. So the margin is defined as the border of interface of a nodule to the thyroid tissue and surrounding extrathyroid structures. So it could be smooth, ill-defined, lobulated, or irregular, or have extrathyroidal extension. And again, you can see in this graph here, a lobulated or irregular, specifically solid nodule at the top here has a greater risk of malignancy, and that's why it's given 2 points. Smooth nodules are given 0 points. They're uninterrupted and well-defined with a curved linear edge. This is usually your spherical nodules and your elliptical nodules that you'll see. Ill-defined nodules are also given 0 points. And these are just nodules where it's difficult to distinguish the nodule border from the thyroid parenchyma, or if the thyroid nodule abuts other nodules, which makes it difficult to see where to measure it, like in this example here. Then we have lobulated or irregular nodule margins, which are given 2 points. For a lobulated one, you'll see soft tissue projections coming out from into the thyroid parenchyma. There could be multiple or just a single one. And irregular nodules will have a jagged, spiculated, or sharp angles in it, as seen here. This is another example of a kind of lobulated irregular nodule, similar to the echogenicity of isoechoic and hyperechoic nodules. Lobulated and irregular margins are both given 2 points, so it's not important to be able to distinguish the difference between them. And the last one we have is extrathyroidal extension, which is given 3 points. It's most definitely related to malignancy. As you can see here, this nodule is very irregular in shape, and it kind of interrupts and passes the thyroid border here, where you lose that kind of echogenic capsule layer. Next, we have echogenic foci. This is the only category where you would choose all that apply. And so an echogenic foci is defined as a focal region of marked increased echogenicity within a nodule relative to the surrounding tissue. So you could have none or large comet tail artifacts. There could be microcalcifications, peripheral rim calcifications, or punctate echogenic foci. So here, these are just another graph to show the number of points allocated and the risk related to them. And you can see that if a nodule has, say, a peripheral rim calcification and a macrocalcification, there is an increased risk of malignancy compared to just one or the other. And that's why in this case, we do total the points. So to start, we could have none or large comet tail artifacts. This nodule would be given 0 points. And so a comet tail artifact will have a reverberation greater than 1 millimeter. And you can see that attenuation there producing that triangular effect. And then we have microcalcifications, which is given 1 point. These are very large calcifications that will produce a posterior acoustic shadow. They can be irregular in shape, and there could be multiple of them. Next, we have a peripheral rim calcification, which is given 2 points. It could be complete, as seen in this nodule here, or partial, and it often obscures the central component of the nodule. And lastly, we have punctate echogenic foci. These are given 3 points. These will have no shadowing, and they will have no to possibly some small comet tail artifacts that are less than 1 millimeter in size. So here we can see there's a single echogenic foci here. Even if there's just one, we would still deem this, give this nodule 3 points. And in this example here, we can see it looks like it might have a comet tail, but if you measure the AP diameter, you see that it's less than 1 millimeter in size. And so this would be called a comet tail, not a comet tail, punctate echogenic foci. It's important to also be able to distinguish a punctate echogenic foci from other speckled dots and dashes. That could be a machine technicality. So you really want to look at the echogenic foci within the nodule and kind of compare it to the surrounding parenchyma. Here are other examples of the punctate echogenic foci. They're also given 3 points because they're often associated with semaminous calcifications that are seen in papillary thyroid carcinomas. And again, some more examples showing that these kind of look like comet tails, but if you do measure them, you see that they're less than 1 millimeter. I think that's really important to know and remember. So overall, for the TI-RADS takeaway, it's important to scan the entire gland first so you can survey all the nodules and kind of focus on the more suspicious ones. You don't want to obsess over characteristics with similar point values. So a hyperechoic versus isoechoic nodule, or a lobulated versus irregular nodule. And in the cases of cystic or spongiform nodules, there's no further characterizations for that. And it's also important then to document nodules that are palpable findings or nodules seen on other imaging such as CT, MRI, or a PET scan. Overall, as Dr. Bruni said, we're going to have this sheet posted everywhere so techs can get familiar with each category, the sonographic features, and the points allocated to it, because it's very important to be able to classify and document the most suspicious nodules for appropriate management. As you can see here. Overall, for the management of the nodules, a TI-RAD 5 nodule will be deemed at least 7 or more points. These nodules will be followed up if greater than 5 millimeter in size, and they'd be FNA'd if greater or equal to 1 centimeter in size. If they're being followed, they'll be followed for 5 years annually. And after 5 years, if it's stable, we'd stop the following it up. However, if there is growth, then you'd start it all over again from year 1. Usually growth, as I said earlier, is defined as a 20% increase in size in at least 2 dimensions or a 50% increase in volume. Then we have a TI-RAD 4 nodule, which is between 4 to 6 points. We would follow this nodule up if it's between 1 to 1.4 centimeters and only FNA it if it's greater or equal to 1.5 centimeters. A TI-RAD 3 nodule will only be biopsied if greater or equal to 2.5 centimeters, and there is no follow-up if it's less than a 1.5 centimeters in size. A TI-RAD 2 or TI-RAD 1 nodule, which is 0 or 2 points, there is no follow-up at all. And this kind of just gives you a good idea about how TI-RADS works, and it's more focused on the points and the sonographic features of a nodule rather than the size. As you can see, a TI-RAD 3 nodule wouldn't even be biopsied unless it's greater or equal to 2.5 centimeters compared to a TI-RAD 5 nodule, which would be biopsied if it was just 1 centimeter in size. Overall, there are always going to be some exceptions to the TI-RADS protocol and management. This is not as important to take away for sonographers, but it's just good clinical information to know as well. So some examples of where you might do an FNA would be if a patient already has a known parathyroid adenoma and they have a nodule. We might biopsy that nodule just because if it is known to be confirmed as cancer, they can then go for surgery and take both out and remove the thyroid gland as well. In cases where you see a TI-RAD 4 nodule, but the patient's presenting clinically with neck pain, you might hold off on that the FNA just because it might be related to thyroiditis. Another example here it's also important to check previous, because in this example, we can see that this nodule might look solid and very hypoechoic. However, if we looked at the previous, we would have known that it was a complex cyst last time we saw it. So it just goes to show that we probably don't need to biopsy this nodule, and it's most likely benign. Another important fact to mention is that sometimes color Doppler can be helpful as well in describing the nodules. It's not included in the TI-RADS, but color Doppler can be very helpful in determining if a nodule has solid component, or if that area is actually necrotic hemorrhagic tissue. Here's another interesting exception, where if you have a nodule in the posterior gland on the left side by the trachea and esophagus, there might be involvement of the recurrent laryngeal nerve. This would increase the risk of post-op morbidity or surgical complications. And so we want to be more aggressive with the confirmation, the follow-up, and the biopsy of a nodule in this area. This is an actual example of a papillary thyroid carcinoma in this area. And then sometimes nodules that might be a TI-RAD 5, but less than 5 millimeters, might also be biopsied if there are suspicious lymph nodes as well. In this case, this is an in-house example of a nodule that was biopsied because of a suspicious looking lymph node. If you take a look at the nodule here, it doesn't really look very concerning or kind of eye-catching. It just a little bit ill-defined here and hypoechoic, but it was a confirmed case. And I've also added 2 other confirmed cases here of papillary thyroid carcinomas. I personally find that we do lots of biopsies and we fill up all these nodules, but we don't always get to be in on looking at the final results of these FNAs. And so it was just interesting to see that these 2 were the actual confirmed ones. In this first image here, you can see it's relatively small. It doesn't catch your eye at all. It's just a bit irregular and hypoechoic, but it was a confirmed case. And then here is, in contrast, a very obvious case with the extrathyroidal extension, this lobulated irregular nodule here, with the presence of abnormal lymph nodes as well. So this brings me to talk about the sonographic evaluations of lymph nodes now, because the appearances of lymph nodes may affect the decision to do an FNA. So we do want to scan and document suspicious lymph nodes. Most commonly, lymph node involvement will be in level 6, which is inferior to the thyroid gland. And then level 3, 4, and 6 involvement has the worst prognosis because it leads to extensive neck surgery. Usually level 2 lymph nodes are not commonly involved. For a nodule that's in the upper pole, it is likely to skip METs in level 2 and 3. And in the absence of other node enlargement, level 2 nodules tend to naturally be larger in size, so that's not concerning. It's very important that we don't over-document lymph nodes and measure them if they're normal in size. And it's more important to look at suspicious sonographic features, especially when we're looking at young patients too. They'll have more lymph nodes and they tend to be larger than the older populations. So sonographic evaluations of lymph nodes, for suspicious lymph nodes, they might have sonographic features such as microcalcifications, being round and at least 8 millimeters in the short axis. There could be hilar compression, displacement, or replacement, cystic or necrotic appearances, peripheral vascularity, or hyperechoic tissue comparable to the thyroid gland. So here's an example of some microcalcifications in these abnormal lymph nodes here that look suspicious. As you can see, just in that area there. And then here we see some more round and even irregular shaped lymph nodes that have hilum displacement, replacement in this one here. So these look also suspicious, and we would definitely document these. And then sometimes you can have cystic or necrotic appearances. So here we can see the cystic area here and the small one developing there. And lastly, some examples of the hyperechoic tissue comparable to thyroid gland, as you see here. And this is the lymph nodes that are metastatic from thyroid cancer because of intranodal thyroglobin deposits. So that's the end of the talk. Essentially, but now I have some case review that I'd like to go through with everyone and get some participation going. So I have a nodule here. Does anyone want to participate in categorizing the criteria for this nodule?
Is there anyone who wants to just try out categorizing this nodule?
Yeah,
Okay,
sure,
I'll
I'll
break
give it
the
a
ice
try.
with Derek. Oh, go ahead, Kelly.
Yeah, Kelly. It's a solid nodule. Looks like it's tall and wide, hypoechoic. The margins are circumscribed. There's looks like there's some echogenic foci within the nodule, microcalcifications.
All right. Yep. So I would agree with that here. It looks like it's solid, hypoechoic, and taller than wide, as we can see the measurements in this transverse view. It's difficult to assess in this one, but it might possibly have a peripheral rim calcification as well. So if we add all these points together, it'd be 12 points in total. And so that would be a TIRAD 5 nodule, which is highly suspicious. And we would FNA a nodule like this if greater than 1 centimeter. So definitely this one here. Right. And now our next case, any other volunteers? Maybe from, we'll try M site for this one.
Any of our sonographer colleagues who want to try it out?
Want to just talk?
Yeah, go ahead.
It's fairly isoechoic. Margins very, pretty defined. Is that a microcal? And it's longer, it's not taller than line, so looks like it's taller than line. Yeah. So 1 or 2 points.
All right. So, yep, this nodule is solid. It's isoechoic and wider than tall, and it's relatively smooth margins. I did measure here this area because it was a bit tricky, but if you actually measure the depth of it, it's greater than 1 millimeter. So I would call that a comet tail artifact. So it would be 3 points, which is a TIRAD 3 nodule. It's still relatively large in size, so it probably, if it was greater than 2.5 centimeters, it would be biopsied. All right, and now I have another one. Anyone from QSite want to give it a try? Any volunteers?
Don't make us pick on you. Any of the radiologists maybe jump in and do it? Okay, maybe
Can you hear me?
we could just go through them.
Okay, sure. So for this nodule here, it'd be mixed solid cystic. It's relatively isoechoic. There's some areas that look echogenic. So again, you can say it's hyperechoic. It'll just be given 1 point. This nodule is actually taller than wide, as we see in this transverse view here. It's relatively smooth, and there's no echogenic foci, so it'd be given 5 points, and that would be a TIRAD 4 nodule, which is moderately suspicious. And you would do an FNA if it's greater or equal to 1.5 centimeters. And then we have this one here. This one's really easy. Does anyone not want to give it a try?
I'll try.
Okay.
With the shadowing, I think you said you give it 2 points for composition because you can't tell.
Mm-hmm.
Echogenicity, I don't remember, but you can't tell either. And again, with the shadow, I'm a little confused here because it's shadowing, so it's going to be hard to tell if it's taller than wide. On this one, it looks taller. And the margin can't actually, you can't tell much except that it's covering calcification.
Yeah, so this is definitely a nodule where you can't tell much. So the composition, you'd give it 2 points and you can't tell. Echogenicity is 1 point for not being able to tell. It's difficult to assess just from a picture, but I call this wider than tall here. But it is difficult to assess that. It does look like it ends here though. And again, with the margins, you can't tell, but that would just be 0 points. And this is a peripheral rim calcification, so that's given 2 points. So if we add those points up in total, it would be 5 points, which is a TI-RAD 4 nodule again. And for our last one here, we have this very irregular shaped nodule, and then you see the presence of some abnormal lymph nodes. So for this one, I'll just go ahead and give the answers up there. So it is solid. It's hypoechoic and taller than wide in this image here. It's very irregular, has lobulated little margins here. And there doesn't seem to be any echogenic foci. So the total would be 9 points and it would be a TI-RAD 5. Specifically, even with these abnormal looking lymph nodes, it'd probably already caution biopsy. And so that's it for my part. I'm just gonna send that back to Dr. Bruni now to kind of wrap things up.
So once again, I'd like to thank Elaine for really a lot of excellent work put into this talk. I just want to highlight the fact that all of the images, all of the cases that were presented in this talk were taken from our institution. So there was a lot of work in collecting all of these cases and putting this talk together. So really a big thanks to you. I sincerely hope that, as Ivan mentioned, this is really just the beginning of what will become a robust, collaborative, and peer-driven continuing medical education series in the ultrasound department. So stay tuned over this summer for some additional talks around some of our other amended ultrasound protocols, and as well as some interesting case rounds and didactic talks regarding some common sonographic mimics. Before we wrap up today's session, I would like to review a few specifics from the updated thyroid protocol as it pertains to documentation and measurement technique. So as Elaine discussed, under the TI-RADS system, really only the 4 most suspicious nodules are generally reported in our final reports. Over time, I'm certain that you'll all become so familiar with these criteria that you'll really be able to easily pick out the most suspicious 4 nodules on a cursory initial sweep through the gland. However, in order to make things a bit easier in terms of deciding what to document and what to ignore, our newly revised protocol does include some specific criteria which determine whether or not a nodule should be documented and measured. So as a general rule of thumb, I would say the absolute maximum of documented nodules should be at the upper limits 3 nodules per lobe and up to 2 in the isthmus. Although you may document up to 8 nodules and measure them, only the 4 most suspicious are going to end up being recorded on the worksheet and reported. So just to try to save on unnecessary work, there is an upper limits of how many nodules you should be going ahead and documenting. So in terms of determining which of those nodules should be documented, there's a priority list that you should go through. And the number 1 priority should be any nodule with highly suspicious features, regardless of what size they are. So those high suspicion features are going to be microcalcifications, very hypoechoic nodules, irregular or lobulated margins, or extrathyroidal extension. So those points that are going to give you 3 points right off the bat, those are ones that really at any size, those are high risk nodules and should be recorded. Beyond that, the next most important criteria in terms of determining what an index nodule is would be any solid or predominantly solid nodules over 1 centimeter. And then finally, any nodule that's greater than 1.5 centimeters, so spongiform nodules that are greater than 1.5 centimeter. If there are no other nodules that take up those first 7 nodules that you've documented, then you can document any nodule over 1.5 centimeter. But otherwise, like if you've already documented 7 or 8 nodules, And then there's a few additional large spongiform nodules. I would say that there's no need to document those if you've already hit your upper limits of 8 nodules. So additionally, regarding non-index benign appearing nodules, I would say that only the single largest of these needs to be documented with measurements. And similarly for simple cysts, I would only really ever document the largest cyst and only the longest dimension measurement for that cyst. We don't need 3D measurements of simple cysts. It's unnecessary. Those aren't concerning lesions, and we don't really need to document those. So if you can go on to the next slide. So in terms of how to measure the nodule, I think a bit of standardization in our approach will go a long way in ensuring that follow-up comparison studies are the most accurate that they can be, and we don't have as much inherent variability in terms of measurement technique that invariably you're going to end up with if everyone's using a different way of measuring. In addition to that, I would say the other benefit of trying to standardize our measurement approach is that once we have the ability to strip or export DICOM data into a report, measurements of these nodules will automatically be able to be ported over to a report template and will alleviate the need of us manually recording this data onto a worksheet. So I'd like to get ahead of things right off the bat before we actually have that ability, just so that once we start moving over to automated reports or web form reports, that we are already set up for that. So some of you probably already employ this method for measurement, but for others, it may be a bit of an adjustment from what you normally do. But I'd ask that you try your best to adhere to this going forward. So for nodules that are small enough to do so, I'd ask that you try to take a sag and transverse image of the nodule on a split screen grayscale image. And then this can be stored. And then
being able to
measurement
in an appropriate phase. Obviously, the tourism sector, I don't have to tell you, I'm speaking to you from Atlantic.
So, sorry, I think someone is not muted. Yeah, so this should be stored without measurement calipers, and then a second image stored with the measurement calipers on. In terms of measurements, the longest dimension of the nodule should be measured on that long axis, the sagittal plane. And then on the transverse image, the longest dimension should be measured with the third orthogonal measurement taken to 90 degrees relative to the long axis measurement on the transverse image. For each of these measured nodules, a single transverse image can then be taken with color Doppler just to show whether or not a solid component is indeed vascular and solid tissue rather than just debris. So if you go to the next image, here you can see an example of kind of the expected split screen documentation for this sponge of what is an otherwise benign spongiform nodule. So I would say generally for a spongiform nodule, less important, but here just as an example, on the left, you can see your initial capture without the measurement calipers on the right with the measurement calipers. And in terms of how to measure, again, on the sagittal image, longest axis dimension, it may not be perfectly within the craniocaudal plane. If it needs to be a bit oblique, so be it, but just get that longest axis measurement. And then on the transverse image, similarly, the longest axis measurement, and then 90 degrees relative to that long axis measurement to get your third orthogonal plane. And that will give us a consistent way of getting consistent measurements from study to study and allow us to more accurately compare nodule sizes. So if you go to the next slide. So briefly, I'll also go over a couple of the details regarding lymph node documentation on the updated protocol. First of all, I should note that a nodal survey is not routinely included or should not routinely be included in the thyroid exam, but should be done if there is any solid nodule in the thyroid greater than 1 centimeter in size, or if any abnormal appearing nodes are seen during the thyroid portion of the exam. Otherwise, I would keep nodal surveys only to be performed if they're specifically requested, or if the history provided is of generalized neck swelling or pain, then I would say include a nodal survey. So when doing a nodal survey, I really can't stress this enough. As Elaine mentioned, normal nodes really don't need to be measured, and nodal size in and of itself is not necessarily suggestive of suspicious involvement or pathologic involvement. And I would say that if you don't see any abnormal nodes and you wish to take an image or two of some representative normal nodes to show that a nodal survey has indeed been performed, I think that's fine. But I would say don't waste your time in measuring otherwise normal appearing nodes. So as with thyroid nodules, I would say that abnormal nodes should be documented with a dual screen side-by-side image of the long axis of the node and then the orthogonal transverse axis of that same node, without and then with measurement calipers if it is an abnormal node. And then a color Doppler image of the long axis of the node should also be obtained, showing the normal vascular pedicle if it's present entering the node hilum, or any abnormal vascularity around the periphery of the node. So if you go to the next slide, again, this is just a bit of a quick revisit of what Elaine has already discussed regarding some suspicious node features. As with suspicious thyroid nodules, really the presence of microcalcifications or irregular or lobulated chorices is extremely suspicious. That's definitely an abnormal node, should definitely be documented and measured. Similarly, significant heterogeneity or hyperechogenicity within the nodal cortex or cystic spaces within the node, also very suspicious, also requires documentation. In terms of round shape or loss of the fatty hilum, generally with smaller subcentimeter nodes, I can find that these can often look a bit rounded, with perhaps some reactive thickening of the cortex that can completely compress or make it look like there's no fatty hilum, and look as if they're solidly hypoechoic. I would say it's reasonable to document those as well. Most of those are just reactive benign nodes, but if you do see those and they're sizable, I would say document them. And then finally, if you do find vascularity at the periphery of the node as opposed to just within the hilum, as would normally be expected, this is too considered suspicious and should be documented. So again, as I mentioned before, and as Elaine mentioned, nodal size is generally a pretty poor predictor of malignancy, with really numerous reasons why a node might be considered enlarged. And furthermore, it really should be noted that those upper cervical nodes, particularly in level 2, generally are not involved initially in a thyroid cancer. Occasionally, upper thyroid pole thyroid malignancies can skip levels 3 and 4 and go straight to level 2. It's relatively infrequent. It's usually you're going to have involvement of level 3 and 4 before you have involvement of level 2, and level 2 just generally is not that commonly involved. In addition to that, level 2 nodes are just generally larger than the lower cervical nodes. So we accept a little bit more in terms of size criteria before we really consider those abnormal. So generally, I would say in terms of documentation, if a lymph node in level 2 is not as long short axis, then I would generally not document until they get up to about the 1 centimeter size. Level 3 through 6, I would say document over the 8 millimeter short axis. I do recognize that we don't tend to use the short axis measurement of lymph nodes, at least on CT. Generally, it's the long axis measurement that's used, but in ultrasound, unfortunately, it doesn't really apply in terms of the measurement criteria that are used in the neck for head CT are not really transferable over to ultrasound, as it's supposed to be the long axis on an axial image of the neck. And in level 2, we actually accept up to 1.5 in terms of the long axis measurement. So I would say, just as a general rule of thumb, I would use these showed axis measurements for ultrasound. And then if you can go to the next slide. So this is the updated worksheet that's modeled on the recommended worksheet from the CCO and includes the acronyms for each of the TI-RADS criteria, which are to be circled for each of the recorded nodules. Again, there's space for recording the 4 most suspicious thyroid nodules on the sheet. And then you'll also note that in addition to the current size, there's also a space to record the prior size of any recorded nodule if applicable. Aside from that, in addition to the overall gland size, there's now also space to record background vascularity for the gland. So you can document if there's any hyperemia that may suggest increased vascularity related to thyroiditis. So as we currently do, if nodal survey is performed and there's abnormal nodes detected, then I would say a separate node worksheet should be used for documentation. Otherwise, if the nodal survey is normal, I would just indicate on the thyroid worksheet that this was done and that NAD, nothing was detected. And just on the last slide, so here's just a zoomed in version of the thyroid nodule table, which on the left has some space for current and previous measurements denoted with C and P respectively. And then for each node abbreviation for each of the categories, which can be simply circled depending on the nodule features. So again, the first 4 categories, that being composition, echogenicity, tall versus wide, and margin, only a single criterion should be circled for each of these nodules. Whereas for echogenic foci, you can circle as many as there are for that particular nodule. So you can go to the last slide. Again, massive thanks to Elaine for a fantastic talk. Thank you all for your attention. Please do not hesitate to email, message on Sectra, or call me at any time if you have any questions or concerns regarding this protocol, or really anything else that you'd like to discuss in ultrasound. I'm completely open door. Please just approach me with anything. Additionally, just to reiterate that what Ivan mentioned initially, if you do have any ideas for talks or topics that you think would be useful to cover, if you're interested in giving a talk at some point, or you want to collaborate on a talk, please reach out and we can explore further. Always happy to help out in that regard. I think there was a number of questions that I just saw in the chat, so I think maybe we'll try to go through some of those. So yeah, Kathy just mentioned that the measurements should be orthogonal, not just in thyroid, but pretty much anything. I wholly agree. That's what I tend to do on my CTs for measurement. I try to take the longest axis of the lesion on the axial, take an orthogonal measurement to that, and then take my craniocaudal orthogonal to that if I'm going to take a craniocaudal measurement. But at the very least on your axials, I would recommend, I know there's some variability in the way that people do things, but the way that I was taught, and this is something that I brought back from Sloan Kettering that we did there, was orthogonal measurements, longest axis, and then your 90-degree orthogonal with respect to that. Yeah, so in terms of the short axis measurements of lymph nodes, yeah, I agree. It doesn't fully apply, but we just need a way of kind of giving some guidelines for where we need some cutoff in terms of documenting nodes. So I think that's a reasonable cutoff in terms of documenting lymph nodes based strictly on size criteria. But again, you know, the suspicious features are really what we're looking for. In terms of cortical thickness, as Kelly brought up, you know, if you do find that you're completely losing the hilum. It may relate to cortical thickening. So significant cortical thickening above, I'd say, usually 3 to 4 millimeter. You can document those nodes as well. Most of those are going to be benign, so I wouldn't go crazy documenting every thickened node. But if there is some cortical thickening, it's reasonable to take 1 or 2 representative nodal images to show that there are some thickened cortices, thickened lymph nodes. So long as they still have a preserved normal vascularity, generally those are going to be reactive. Most radiologists are going to report that as much, and then we're going to follow them up with a short-term follow-up to see if they've resolved. Often I find in the upper neck, a lot of these nodes can look a little bit thickened, they can look a little bit prominent, and they're completely normal. They don't change over time. They're not necessarily reactive. That's just normal upper cervical nodes. Yeah, so as Kathleen mentioned, really morphology is the most important predictor for lymph nodes, and I wholly agree.
So Silvio, I'm thinking about these little round lymph nodes, and where, let's say it's round, it's obliterated, the fatty hilum. And I've seen them, sometimes they measure the full width. That's not the cortical thickness. Would the cortical thickness just be half of that? Presumably they're not all squished and flat, and it's just really half.
Exactly. And that's why I find that the sub-centimeter nodes are quite difficult, because you're right. For the most part, the cortical thickness is actually half of that short axis width, with a effaced fatty hilum that you just can't appreciate in the middle of that. I would say, again, I would treat those similar to the cortically thickened nodes, where it's reasonable to document 1 or 2 of them, but for the most part, not as concerning as some of those other morphologic criteria that are much more higher suspicion. And then just the last question from Carolyn with regards to whether general clinicians are aware of TI-RADS. For the most part, it does seem that more and more institutions seem to be using TI-RADS. Even a lot of the outpatient ultrasound clinics appear to be using TI-RADS. So I think most clinicians are becoming more familiar with this. At the end of the day, it's up to the radiologist to include the TI-RADS, the final TI-RADS number and classification, and then whether or not the radiologist wants to include the level of suspicion that's associated with that TI-RADS number. Generally, I don't. I just give the TI-RADS number, and then our template, our TI-RADS template, or our thyroid reporting template includes the criteria at the bottom, with the recommendations with regards to each of those each of those TI-RADS levels. So I'll just give for example, TI-RADS 4, and then if the nodule does satisfy criteria for sampling, then I'll state that sampling would be advisable under this size. Aside from that, again, there are extenuating circumstances. Some of those borderline nodules, you don't need to perfectly adhere to the TI-RADS criteria. This is for the radiologists. If you think that a nodule still should, because of the clinical scenario or a significantly increased growth of that nodule, but it's still borderline based on the criteria, I think it's perfectly reasonable in that scenario to recommend biopsy. You don't need to fully adhere to these criteria. It's just to provide a framework for what to do with most of these nodules, and allows us to have better agreement and predictive value with regards to those. So if there's no other questions, again, thank you all for attending, and really fantastic job from Elaine, and I hope that we can continue doing more of these. Elaine, any final remarks?
No, thanks to everyone for listening and thank you, Silvio, for letting me kind of join in on this presentation today. It was a lot of interesting work to put in, and I hope everyone learned something from it and that we can start incorporating this as soon as possible.
All right, thanks again, everyone. Have a good afternoon.